Tuberculosis and HIV have long been two major public health threats worldwide. A crucial part of addressing these threats is to limit and control their spread. Interestingly, despite being distinct diseases, TB and HIV have a deep and surprisingly interconnected relationship. A global study by the World Health Organization unveiled that people living with HIV, hereafter referred to as PLHIV, have a 14 to 20-fold increased risk of developing TB due to a weakened immune system compared to people who are not infected with HIV. And even though they are already receiving anti-HIV treatment, PLHIV are still 3 times more likely to die during TB treatment compared to people who are not infected with HIV. This alarming data led the WHO to strongly recommend that all PLHIV should be routinely screened for TB. However, current testing methods are limiting, as they typically only detect one disease or the other. For instance, Abbott's Alinity and Roche's Alexis only detect HIV, while QIAGEN's QuantiFERON and Oxford Immunotech's T-Spot only identify TB. Addressing this challenge, researchers at Tulane University have recently developed an innovative rapid test that simultaneously detects both HIV-1 and TB from just 4 drops of blood. Impressively, this test not only identifies the presence of both diseases, but also quantifies the viral and bacterial load within the patient's body. The researchers first targeted 2 classic markers for detecting HIV and TB, the P24 protein of HIV-1 and the CFP10 protein of tuberculosis. Despite their usefulness in detection, these proteins have limitations, including easily binding to the patient's antibodies, reducing their detection sensitivity and potentially leading to false negatives. To overcome this, the researchers extracted specific peptides of these proteins, P24 peptide EW-R and CFP10 peptide TAGNF-ER, and verified the peptides by immunoaffinity liquid chromatography tandem mass spectrometry, hereafter as ILM, to verify the signal intensity of these 2 peptides, demonstrating the recognizability of the signals and the linear consistency between the signals and concentrations. To test the clinical performance of this method, the researchers analyzed cryopreserved plasma samples from 23 adult active TB patients and 11 asymptomatic household contracts. They were previously enrolled in the TB aerobiology, infectiousness, and transmission cohort in Kenyan. Researchers also analyzed cryopreserved serum samples from 13 children with both TB and HIV-1, as well as 4 control children who were at risk for TB-HIV-1 exposure but showed negative results. These children's sample are from the International Maternal Pediatric Adolescent AIDS Clinical Trials IMPACT P1041 study. Finally, the researchers eventually purchased 5 HIV-1 seroconversion panels samples from SeraCare. Upon enrollment, researchers immediately used methods such as PCR ELISA, culture GeneXpert to determine HIV and TB in samples, and reevaluated samples that showed negative at baseline after 6 months and 12 months. These samples were also tested with ILM. The final results showed that the sensitivity of ILM for detecting HIV was 85.7% in adults and 88.9% in children. The sensitivity for detecting TB was 100% in adults and 88.9% in children. The specificity of ILM for HIV and TB was 100%. The performance of ILM in HIV-1 seroconversion samples was also impressive. It could detect HIV-1 positivity in patients an average of 5 days before other HIV antigen, nucleic acid, antibody nucleic acid methods detected positive results. And it showed a strong consistency with HIV-1 RNA and P24 protein concentration detected by other methods. In addition, researchers also verified whether the new tool could monitor treatment effects. After 6 months of ART and ATBT treatment, the serum concentrations of P24 and CFP10 peptides decreased in 2 P10s and 41 children who showed treatment effects. The serum concentrations of P24 and CFP10 peptides showed an increase in 2 P1041 children who did not show improvement. Although one child developed immune reconstitution inflammatory syndrome after ART treatment, the serum concentrations of P24 and CFP10 peptides still decreased, but the decrease in HIV RNA did not completely match the decrease in P24 peptides. The ability to qualitatively and quantitatively detect HIV and TB with just 4 drops of blood is definitely a tantalizing technology. Although there are already many products for blood testing of HIV on the market, TB is still largely diagnosed by sputum culture, and there is a lack of blood testing products. If HIV and TB can be detected simultaneously, this technology has immense potential. This study only validated about 50 samples, and we look forward to including more samples in the future. If this pilot study can enter clinical trials soon and get approval from the FDA and other national health institutions, it will add an important piece to the puzzle of high-risk infectious disease detection.